So Alan getting very eager there. Welcome everyone, I'm Councillor Matthew Williamson, Cabinet Member for Community Wellbeing, Health and Care. If the continuous fire alarm sounds, please evacuate the room and public gallery. No one in the public gallery today. By the stairwells, please do not attempt to use lifts. Please assemble in the turning circle at the end of King Henry Street, past the University's Park building. Of course, not different from usual as we've got the ice rink out in Guildhall Square. I don't think anyone would have signed in. There's no members of press or public. Please can everyone use the microphones and remember to switch them off when they are finished. So, and if we do introductions starting to my left with you, Alan.
Alan Noble, Public Health Principal.
Anna Martin, Democratic Services.
Andy Biddle, Director of Adult Social Care.
Emma Baxter, Finance Manager.
Helen Atkinson, Director of Public Health.
Councillor Graham Heaney, Labour Group Spokesman for Community Wellbeing, Health and Care.
Councillor Matthew Cordy, Hilsey Ward.
Spencer Gardner, Member for Drayton and Farlington.
Thank you very much, everyone. Members, apologies for, we have no deputation requests. We have no apologies for absence, though we do have an apology for lateness from Dominic Latous, who is going to be doing the annual public health reports. She's currently on a train and delayed, so if need be, we might bump that agenda item down until she arrives. Members, any declarations of interest? No. Okay. Without further ado then, Alan, the Combating Drugs Partnership Annual Review, over to you.
Thank you, Chair. Just come to present as an information item the Combating Drugs Partnership Annual Review for 2024. In case you're unsure of what a Combating Drugs Partnership is, as part of the government's 2021 National Drug Strategy, there is a requirement for all local areas to set up a Combating Drugs Partnership. These partnerships were to bring together a range of local partners that cover the broad kind of area of drug-related harm or can work together to try and tackle drug-related harm, and that would include enforcement agencies such as the police or probation, prevention, so some of the young people services, treatment, that's specialist treatment services for drug and alcohol dependency, and recovery, which is often peer-led services where people with a lived experience support each other to find recovery. And the Combating Drugs Partnership, which I'll call the CDP from now on, it provides that single coordinating body to understand what the challenges are for Portsmouth and then develop a joint plan on how we tackle them based on what the needs are for Portsmouth. So Portsmouth Combating Drugs Partnership covers the city of Portsmouth. That might sound strange, but we were encouraged at one point to look at wider geographies or geographies based on potentially the police force areas, but we took a decision in Portsmouth to have our own partnership because the city is quite different to other parts of some of the surrounding areas, and we have our own needs and issues which are different from those areas. But the membership of our local Combating Drugs Partnership includes representatives with a lived experience. That includes people with a lived experience of their own drug or alcohol dependency, but also carers who have a lived experience of a loved one who has a drug or alcohol dependency. Portsmouth City Council is well represented by members and various key departments. Hampshire Constabulary, the Office of the Police and Crime Commissioner, probation, and then some of the health organisations, Society of St James, who are our lead provider for drug and alcohol specialist treatment services, and Health Watch, and the University of Portsmouth. So all the key stakeholders within the city. there is a requirement for the CDPs to have certain key functions or key roles filled, and the senior responsible officer, who effectively is the owner of the Combating Drugs Partnership, is Helen Atkinson, Director of Public Health, myself as the Partnership Support Lead Officer, and then we have leads for public engagement role and data and information. And those posts or roles are required by the government as part of the strategy. So I previously mentioned that we did consider the Hampshire and Isle of Wight footprint for a combating drugs partnership to cover that area, but took a decision that because the localities are so different, that wouldn't necessarily work in our area. However, we do work closely together, and we have I'm trying to think of the name of it, but we meet with the Police and Crime Commissioner on a quarterly basis, and all the areas come together with the police and probation to look at the Pan Hampshire area and issues that we've got around drug supply and drug-related crime that are common, and issues, for example, where a lot of our offenders will go into Winchester Prison, so there's prison liaison work. Areas that actually do benefit us working jointly, we do that. So Portsmouth, we completed a very detailed needs assessment of our drug and alcohol issues within the city, and we identified 6 kind of key priority areas. There are actually, it's a 101-page document, so there's a lot more information in it. I'm just trying to distill it as best I can, but we identified for a lot of our drug and alcohol users, drugs and alcohol isn't the only problem that they have. Often they'll have very serious physical health problems and mental health problems. Often they're contributory factors to their drug and alcohol use, and there's a bit of a vicious cycle. We had a low number of people with an alcohol dependency in treatment compared to drugs, so it was an area that we tried to prioritise increasing the number of alcohol users in treatment. We wanted to increase the number of people successfully completing treatment and leaving drug or alcohol free, increase our capacity of our young people's service, which had essentially shrunk to 1 worker at the time, and to seek to move away from silo commissioning, particularly where we work with people that have multiple complex needs, so that we don't commission separately from other partners, and that we look to do things collectively and complementary. So in response to the needs assessment, we developed a action plan, which was approved in March 23, and that covers the period up to March 26. And the plan has 3 key priorities. So there's disrupting local drug supply chains and drug-related crime, improving the quality and capacity and outcomes of our specialist treatment services, and reducing the misuse and harm caused to young people by drugs and alcohol. So this progress report, in terms of progress report, the Combating Drugs Partnership receives a detailed report at each quarterly meeting, and it's a report that's called the Monitoring Framework. And it has a range of key performance indicators which are linked to those 3 priority areas. And there are 35 different measures which are reported to the Combating Drugs Partnership. So the following slides are just going to give you a summary of the progress within some of the measures. Some of the data is quite specific, some of it's not, because there is some sensitivity around the data, and some of the data we're not able to publish the specific data until it's approved and finalised at a national level. So this is indicative. So there has been an increased number of drug dealers arrested over the past year, as well as an increase in seizures of heroin, crack cocaine and powder cocaine. There has been a reduction in the number of active county line networks operating in Portsmouth, and they're a priority for us because county line dealers tend to be more violent, more coercive than potentially some of our more local dealers. So That's not to say we don't still prioritise local dealers, but there's specific actions which are taken around county lines because of the higher risks. And we wanted to specifically increase our intelligence that's reported to the police using community partnership intelligence forms. And I'm pleased to say that significantly more intelligence around drugs is reported by Portsmouth partners, including the City Council, to Hampshire Constabulary than anywhere else across Hampshire and the Isle of Wight. And that we've done significant work with our partners such as the Housing Department in training up their staff, and they're a really key reporter because they get a lot of community intelligence. In terms of improving the quality, capacity and outcomes of our treatment services, I guess the first negative is that we have continued to see a rise in drug-related deaths reported. This is a national trend, so it's not something that's Portsmouth specific. There's a range of factors, including an ageing cohort of drug users with complex health conditions which are causing them to die young or relatively young. And more recently, we're seeing issues with synthetic opioids coming into the country, including the city, and these will cause overdose deaths because the drugs are much more problematic than traditional heroin because they're so much stronger that the difference in doses can be very significant. We've had a very significant number of people in treatment. We've increased the numbers in treatment very significantly from around 1,400 up to over 1,900 now over the last couple of years. Primarily those people entering treatment have been alcohol users, which was a priority area for us based on our needs assessment, crack cocaine users and other non-opiate users. So for example, powder cocaine, but also increasingly we're seeing issues with ketamine use and health-related problems linked to ketamine use. In terms of opiate numbers, we've got a very slight reduction in the number of opiate users in treatment. That's something we're prioritising and looking to address, and now there's a very small difference between where we were 2 years ago and where we are now. Successful completions, so people leaving treatment drug and alcohol free, have increased over the past 12 months for all of our substance categories. The percentage of prisoners engaging in community treatment after release remains below the England average. However, we have seen some significant increases over the last 3 months, and the trajectory would suggest we're going to be close to the national average soon. And the number of residential rehab placements, so that's where we send people away to do a period of time in a residential unit, that has increased significantly as well over the past 12 months and is above target on that. In terms of young people, so the number of under 18s engaging in treatment has increased significantly over the past 12 months after significantly falling the year before. Essentially that was a capacity related issue, and it's one where you employ more young people workers, you will get more young people into treatment because they're able to very much go out and find them, which is what is required with a young people's service. We've got an increasing number of children's workforce receiving substance misuse training. There's been an increase in specialist support for social workers. No support for socialist workers. No, but our social workers have been getting increased support, and that's what we call team around the worker support. So the social worker will maintain the caseload, will work with the person, but the substance misuse worker will very much support the worker with what they need to do. That worker, the existing worker would have the relationship with the young person and the family, and it's about maintaining that, not bringing someone different in, but the substance misuse worker will support the worker. And we have seen a reduction in suspensions from Portsmouth schools for incidents linked to drugs. So in terms of our public involvement, this is an area that Portsmouth does well compared to some other areas. So as well as our elected members, I've previously mentioned that we have people with a lived experience very much part of our partnership. We have carers who are very much part of our partnership. They feel they are empowered and contribute as much as the partner agencies that are around the table. And similarly, Healthwatch are an active participant within our partnership, bringing their role as an independent champion for health and social care services. And we do an awful lot of work around engagement with our service users, with the public, with carers, to try and develop and improve the range of services that we offer in the city. And just to highlight how people access support in the city, and there's information available on those websites for adults, for children, and then also for parents and carers who might need support for themselves whilst managing someone with a dependency. So, I'll take any questions.
Thanks very much, Alan. I do wonder if you've been spending a bit too much time with our former colleague and much missed colleague, Mark Sage, who is a prominent member of the local social working party. So, who of course has come to Combat and Drugs Partnership meetings in the past when he's working for the council. So, thank you, colleagues. Any comments or questions? Matt.
Thank you, Chair. You mentioned that the needs assessment from 2022, you wanted to implement measures to increase the proportion of successful completions for drug and alcohol treatment. And you go on and say that the treatment completions are up over the past 12 months, which I congratulate you on. I was wondering, how do you measure that? Is it someone that actually completes the course, or if you don't see them within a year or something, that classes as a completion, or does that, if you were to see them again, would that annul the completion?
Essentially, they're discharged from treatment, and the situation is that they will be discharged no longer using substances. Some people may progress very quickly through the treatment programme and get to that quite quickly. Some might take years. It will be a judgment call based on the person themselves and the worker. So they're essentially, they've finished treatment. We don't necessarily run courses or per se, because it's a journey through treatment often that does take a long time. So it's they've come to the end of that journey and no longer feel they need specialist treatment, and they've left with a positive outcome. Obviously, we do get quite a number of people leaving not knowing what's happened to them because they've just disengaged, or people have relapsed and are still using when they leave. Yeah, so sorry, I don't know if I've explained that very well, but essentially it's an agreed outcome between the worker and the person, and there'll be tests. We test people regularly for drug consumption, so we'll know whether they've been using or not.
Thank you.
Thank you. Anything else, Matt?
No, Chair, thank you.
Okay. Graham.
Yeah, I had a couple of questions. I wanted to focus on that table on page 10 about the number of drug-related deaths. I know you explained that there were some reasons behind drug-related deaths, and that could explain the trend, obviously, in recent years. But I noticed there was quite a spike in 21-22, a significant number. Do we know why that was? Was that something to do with a particular supply of some toxic drugs that caused the problem, or was it something else?
In that particular year, there was an issue one summer with a batch of contaminated heroin, which we found out quite quickly was contaminated with the nitazene, which is a very strong synthetic opioid. That led to, I think it was suspected, 5 deaths within a 2-week period, and so we're talking, our numbers that we're talking about sort of 30 to 40 a year, so an increase of 5, obviously percentage-wise, is a significant percentage. So that particular year there was that batch that did cause us a particular issue, and we had a very high number of overdoses. We would have had a much higher number of drug-related deaths if it wasn't for the work of the staff in our hostels who were administering naloxone very regularly on a daily basis to save lives.
Another question related to the page after page 12. It mentions there's been a reduction in the number of suspensions from Portsmouth schools for drugs related to drugs. Is that because there have been less incidents, or is it because suspension is not seen as an effective measure for dealing with this?
I couldn't give you the exact answer for that. I suspect the latter. There's more service provision available now for them to manage young people and to support young people with issues than there was previously. So it may be that they feel more comfortable to keep the young people in school.
Yeah, because in some senses, suspension might not be the best thing because it takes them out of school, takes them out of contact with teachers and others, and therefore, if you want to get them off drugs, you better have them where you can keep an eye on them more or less, I suppose, is that
correct?
Yeah. Yep. The final question was really related to the general comment at the beginning about disrupting drug supply chains and drug-related crime. Fairly positive, drug dealers arrested, seizures of cocaine and dealing with country networks and community intelligence. But what impact do we think this is having on the overall supply of drugs? Because you might find that all that's happening is the price of it goes up and people are just spending more money. Is it effective in really cutting back on supply and use?
The impact is probably limited because what we do in Portsmouth can't influence what's happening nationally, what's happening in London. A lot of the county line networks are coming down from London. There is obviously the intelligence that we gain in Portsmouth we share with the Met, who will then look at the further up the chain to take out the county lines. We have had information recently that there is a scarcity of heroin in the city, but that's probably more to do with the fact that the Taliban have been cracking down on opium production and people have been using other drugs which they've, such as spice, as a replacement for heroin. So it's a little bit like squeezing a balloon. But that's why really the police prioritise the networks that cause the most harm and are the most high risk, because they're more of a danger to the general public and to young people who they're doing drug running, etc.
Spencer, any comments or questions? Thanks, Alan, for the report. As ever, it's very illuminating. It's important work. I think on that last point, when I'm talking to the police, both at the Combating Drugs Partnership and when we're talking things like the Safeguarding Adults Board and other settings, we know one of their really major focuses is on county lines, and so that obviously fits in very strongly with the work that the Combating Drug Partnership is doing. Anecdotally, Alan mentioned spice there, and I know that's been quite. There's some quite serious instances recently to do with spice, and that often has, it can have all kinds of nasty stuff in it, including, I believe, very potent synthetic opioids. So it's I was on someone who works at the hostels, and it's been particularly unpleasant there in the last few weeks. And of course, there is no regulated market, and it can be all very nasty. And I'm really pleased, though not for the reason it has to be used, but naloxone that Alan mentioned, which was a decision that I made in my first couple of years as cabinet member, to invest in that before it was more widely used nationally, and training people up to use it. And I think that has clearly saved lives over the years. So that's something I think we as a council can be really proud of, that we invested in that at the right time and made sure that we got ahead of the game really in terms of making sure that people were trained up to support people and administer that when people are overdosing. this, as I think Alan mentioned, this goes back to 2021. This is a statutory organisation. We have our regular meetings, and it really does give an opportunity for people to go right across the different areas, both statutory, non-statutory, lived experience, which is so important, and we are getting positive results. And I think Alan, would you say it's been a useful addition to the work we're doing in the city?
Absolutely. Yes, it does take us back to a time when we had something called a drug action team, which was a partnership, very similar. And absolutely that work and talking to each other is of huge benefit.
Yeah, I have to say I think there was some scepticism when it came in. It might just be a bit of a talking shop, but I think we've certainly in Portsmouth we've really made that work, and also building on that with the work we're doing across the Hampshire and Isle of Wight area as well, with the Police and Crime Commissioner and the police and the other statutory agencies in there. So the report is just for noting. Obviously, if anything in particular, we'll keep you up to date within the year, and then obviously we'll be reporting back on this this time next year. But really appreciate the work you've done, Alan, and all the work you and your team do, and obviously in supporting and coordinating in the Combating Drugs Partnership. So thank you very much. So Dominic is now here. Dominic, would you like to introduce yourself?
Hello, apologies for being late. I'm Dominique Latouze, Assistant Director of Public Health.
Thank you, Dom. And yes, there was we understand it was train issues. So it will be over to Dominic, who's going to take us through the annual public health reports when it appears. There we go. Okay, over to you, Tom.
Thanks very much, Councillor Whittington. Yes, so I'm here to present the annual public health report today. This year's annual public health report has the focus of health sustainability and climate resilience. So clearly, climate change is one of the biggest threats to our health currently and in the future. And this report really looks at how that impacts on the people of Portsmouth. And you can see here a number of images of how that's already affecting us. Should also say thanks to the huge team that's put this together, first of all, before I go on. So we've got here some images of how extreme heat is affecting the city. So an image here of the Royal Albert Day Centre, which we'll see a video of in a minute. The coastal defences, and an image here of some children at Arundel Court Primary School who are dealing with flooding. So there's these four themes that you can see here: extreme heat, flooding, air pollution, and insect-borne disease. Insect-borne disease because as a city, we are warm enough to accommodate invasive mosquito species. So we survey or have surveillance at the port for invasive mosquitoes that might come in freight. And that happens across the country, and mostly in the south. So this year we've focused on those four themes, as I say, and we've used 4 case studies to illustrate that through videos. And as I said, we'll show you in a minute the Royal Albert Day Centre and how they're managing extreme heat already in the city. So in terms of our current picture of our health, the Global Burden of Disease, which is an international document, already highlights that 17% of heart disease and stroke and 28% of chronic obstructive pulmonary disorder are linked to environmental and occupational factors in Portsmouth. Clearly, not all of those would be related to climate, some related to occupational factors, but it's a substantial proportion of deaths that are impacted by the environment, and just goes to show really the importance of the environment on our health. And some of that's illustrated here. So we think about air quality. In 2022, the proportion of adult deaths attributable to poor air quality and low long-term exposure to particulates in the atmosphere was 1 in 20 deaths, which is higher than the English average. and over half the population, according to the UK Health Security Agency, are vulnerable to the effects of air pollution. And you can see that the map there illustrates vulnerability delineated by that sort of darker red picture. And it mirrors, as you would expect, along the main roads, which is the largest contributor. Around 50% of our air pollution comes from transport-related links. So you can see that the greater vulnerability is largely along roads, but it also relates to age profile. So the very youngest and the very oldest are most vulnerable. And also those with existing health conditions. And we know that this also mirrors some of the deprivation map of the city. And we know that people living in more deprived areas are more likely to be exposed to poor air quality, but also more likely to have poor and long-term health conditions. So in terms of flooding, I talked about the coastal sea defences, and on the left there you can see the flood risk from coastal flooding without defences, and that's clearly improved. On the right-hand side, which is the flood risk with defences. However, there's still a degree of surface water flood risk that you can see is not mitigated by those coastal defences, and so that's something we really need to think about as a city, and something we are thinking about as a city already. Insect-borne disease, I mentioned. Diseases carried by mosquitoes and ticks internationally cause 700,000 deaths per year, so that's obviously malaria, but also things like the dengue, chikungunya and Zika virus, which are all carried by the invasive tiger mosquito, which is what we monitor for at the port. We're already also seeing risks from ticks. It's a more favourable environment for ticks that carry Lyme disease, and that's something that UK Health Security Agency wants us to keep an eye on as well. So across the country, the UK HSA and local authorities have detected invasive tiger mosquitoes 6 times along those transport routes, tend to be freight, lorries and ports. And then finally, in extreme heat, we're projected to have an increase of around 2 degrees in temperature rise in the city over the next few years by 2050. And correspondingly, summer rainfall is predicted to fall by around 20%, which will link to increased severity and frequency of heat waves, which would have a corresponding impact on heat-related deaths. So there's a lot we're already doing on this in terms of, as a city, and it's a city council and a city-wide approach, but there's clearly a lot more we could do. And some of that's illustrated in this plan on a page, which is a little bit small, but you can see some of the, it talks about those risks, flooding, extreme heat, vectors or insects of disease, carrying disease and air pollution. And it thinks about those actions for change that we might want to start employing in terms of improved quality of housing and building and services, and then improved quality, I've called it, between buildings, so those spaces around the city. And if we make improvements to those, they have corresponding positive impacts to health and to the environment. So we create these sort of so-called co-benefits. So if we take, we're going to look in a minute, as I say, about extreme heat. So if we think about impact, ways that we can reduce the effects of extreme heat, we can make cooler public spaces, for example, through tree cover. But that also has a knock-on benefit, if you see here, by making places more pleasant to be in, meaning people are more likely to dwell in public spaces. They might be more active, which is good for their physical health. It's good for their mental health. It's also good for biodiversity, having more green space in the city, and that will contribute to some of the improved biodiversity in the city. So a lot of these actions to combat climate change have these co-benefits. Clearly, for improved health, we need to think about reducing carbon emissions, but we also need to think about becoming more resilient and managing how our health and how we can mitigate against or be more resilient against those effects of climate change. And I'm going to show you a video now of how that's being done at the Royal Albert Day Centre, which is a centre for, as Eve will explain in a minute, day centre for caring for those with dementia. hoping this is going to work.
My name is Eve Collins and I'm the Unit Manager of the Royal Albert Day Centre. We cater for service users over the age of 65 who have a diagnosis of dementia or a cognitive impairment. We have been, like everyone, struggling with hot weather, and we have several things in place to try and combat that hot weather to make it a much more comfortable place for our service users to be and our staff. Some of the steps we take is to water down all of the paving stones to keep them cool, to help keep some of the heat off, to have good airflow throughout the building, to have a summer menu that's cooler for people to eat, to have summer clothing for our staff so that they're not so hot. For our service users, it's to encourage the fluids. So many people aren't taking in enough fluids, and we have several means by which we encourage people to drink whilst they're here. We have ice lollies and everything for people to keep them cool. We're doing a project this year to help cool the garden. We've got people coming in kindly to help us put plants in that will grow up over to give shade, to give some trees in the garden, to give a bit more shade, because for a lot of people, this is the only outdoor time they get. So we want to get people as comfortable as possible to be able to sit out and enjoy the weather without getting too hot. Of course, we cover all the things like hats and suntan lotions and things, but it's to make the garden and the setting good as well, because people will come in and out as they choose, and you can't always be there to ensure that they've got shade. We try to do as much as we can at the day centre whilst people are in our care. We work closely with public health and with the local authority who gives us warnings on things. And when we take people home, we try to go in and check what the environment's like for their homes. Very often, all the windows are shut. Sometimes the heating's been left on. There's no access to fluids, so we will leave a jug and a drink for people. But we've got many concerns when people go home because there is no one encouraging people to drink. There's nothing to remind them to open the window, to wear adequate clothing so that they're not overheating. We've had some people come to the day centre with winter coats on and thick woolly tops and layers upon layers of clothes, which people have been brought up to do, and they overheat. So we're constantly trying to get people to wear cooler clothes to keep them cool and to keep people safe. Leading on from what I was saying about getting the garden work done here, that's followed from experiences that we had last year, especially when a lot of our service users wanted to come out into the garden and were walking out into the garden, but with this being the only garden they had good access to, and with there being very little shade, we had to restrict their time in the garden to certain times when the sun wasn't round here, because this is the sun trap of the building. We tried to do some activities inside, like the planting, and we did it up at tables, but they wanted to be outside. So that is one of the main reasons why we're so lucky to be having the garden done, to make it more accessible for people, to be able to plan activities more for this summer that we can do outside because they will have adequate shade to sit in. We do not want people coming in and going home with sunburn or heat, heat stroke or anything. It's just about being prepared more for the increase in hot weather, the increase on the days where it's at a dangerous level, and we can have things in place to keep people cool.
Thank you. Any questions? Happy to take any questions.
Thanks, Tom. Any comments, questions, colleagues? Graham?
Yeah, I mean, the issue of air quality is obviously mentioned in the report. It's a difficult one to deal with because one of the issues you said is transport, and currently we don't have any update on what's happening about the clean air zone. Do we know what's going to happen with that? Because obviously it didn't meet the expectations for reducing air pollution in the area. So what is going to happen with that now?
I know that we won't be able to relinquish the clean air zone. As you say, we haven't been able to pass the required. We haven't reduced the nitrogen dioxide in the shortest possible time, which was a requirement of the clean air zone. We're waiting to hear from central government, and I know that transport team are working with the Joint Air Quality Unit, JACU, to find out what needs to be done next. But I don't have any further update from Public Health, I'm afraid.
Do we have any idea when we will hear what is being proposed?
I know that they're right. I know that they're finishing their targeted feasibility study currently and working alongside JACU, but that's a live issue alongside central government.
Thank you for the report. This has been to Health and Wellbeing Board already, and we will be bringing it to Cabinet as well, because we think this is something, as we do with every year with our public health report, it's we do it differently in Portsmouth compared to a lot of other places, and we very much look at it in a holistic way. So this year, obviously, the focus on the environment effectively which is really important to our citizens in the city, and those 4 particular areas which permeate. And I think it's worth saying that the video we saw today is one of 4 videos, each looking at the different areas. So the Health and Wellbeing Board, we had one from schools about flooding. And we had at our briefing, we had one from the port around the airborne viruses, about the insect-borne diseases. Obviously, this one about heat. And what's the air quality one? Dom?
It's an interview with one of our GP registrars about the work he's doing on Clean Air Champions, which is work with clinicians across the city to raise awareness with clinicians, but also so that clinicians can raise awareness with their patients about the risks of air quality, but also think about how they can avoid exposure to poor air quality.
Thanks, Dom. And I think that's the important thing, is it works across all, not just the city council, not just public health, not just things like our care services, but it also covers all the different aspects of what we do in the city. And that's really what we look for in our annual report, is very much about having that that holistic look. Like Dom, I haven't heard anything about the clean air zone. I will ask, see if we've had anything from transport. I'll do that tomorrow, because I'm also interested. It's something that from the beginning, we thought it wouldn't do the job, because it didn't really tackle the symptoms of the issue. It was just and of course, for those of you who know, it's only part of the city, so you can go round it, which only pushes things elsewhere. And I think that the point is that that's actually happened. So some of the areas that are outside the zone have actually got worse, while though not to the extent that they would have liked, we've had some of the areas in the zone have got better. So I think I would hope the government might think a bit more carefully This government might think a bit more carefully than the last one and actually look at, rather than something that is almost a rubber stamping exercise saying we've done something, that it might be something that we can actually have practical solutions. For example, one of the things we asked for was a car scrappage scheme locally, which was never granted, as was actually free travel on buses. I know it's £2, but we asked for that, as well as other things like London level funding for walking and cycling. So I think those would make a real difference to a lot of our work, not just in this area of environment in public health, but also especially with that latter one in terms of people's general well-being and ability to get around the city more easily with doing things in a way that keeps people fit as well. So so great, thanks for the report. It is, as ever, a really important and interesting report, and I think it really does show everything that comes together. I've certainly learnt a lot, especially around the stuff that we do at the ports, about the insects and monitoring for those, because I think I'm right in saying that the insects that the mosquitoes we're trying to keep out are now endemic in Europe.
Yes, I should have pointed that out. Yeah, so there's been a number, and it's actually in the press recently, relatively recently, there's been various dengue outbreaks in Europe, and mostly recently in Paris this summer as well, caused by the endemic populations of this tiger mosquito.
Thanks. So it is a real live issue, and it's about, it might be holding back the tide for a while and it will inevitably come over, but we're doing the very best we can, and the more we can monitor it and that we can do it from our point of view as a port city, the better we are. And obviously we hope our colleagues around the country are also having the same success as well. So that's for noting, and great thanks to Dom and obviously Helen and all the public health team, and of course right across the council, the work that goes on around these areas to make sure that we do the very best for our residents. So, on to item 5. Support for elderly and vulnerable residents in ports of this winter with the RSV vaccine. So this is over to Helen and Andy.
Thank you, Councillor Winnington. So this report is following the October full council motion where the administration were asked to review whether we have the ability to support older members of our society who are excluded from the government's policy to access RSV vaccine via alternative means this winter. You'll be aware, and I'll just pull a few key points from the report, but you'll be aware there's been quite a lot of media coverage over the 4 viruses that are actually obviously contributing to the winter pressures currently. So that includes RSV, but also seasonal flu, COVID-19, but also norovirus, which are all very, very common at this time of year. So government make the decision on vaccine availability and which cohort groups will receive it based on specialist advice from an expert scientific advisory committee, which is called the Joint Committee on Vaccination and Immunisation. They were also the committee, well, they are the committee that made the decisions about the COVID-19 vaccine rollout as well as seasonal flu vaccine. And I put links in the report to some of the evidence that they used to make that decision. So they did look at all of the evidence and made recommendations to government in 2023, which led to the delivery of the current rollout of the vaccine for RSV. So that's based on that evidence, and they both look at cost effectiveness as well as clinical evidence. And it's put this into a context that this is the first rollout of this vaccine that's been available. It is to very young children, it's available, and then it is to this age group in our older, more vulnerable adults, which is 75 to 80. They are very clear that part of the process of the rollout this year will be actually looking at the broader evidence. So it is still possible, even though they made that the decision only to roll out to 75 to 80-year-olds in this current year, that there could be further evidence that will possibly lead to further recommendations for next year. So, as I said, cost effectiveness as well as clinical evidence are very much part of the decision making. And that is obviously with limited and finite resources, and that's both financial but also actually in staffing, because somebody actually has to roll out the vaccine in primary care. So the recommendation, as I said, was to vaccinate just 75 to 80-year-olds. So therefore, it's not currently feasible for the council to support older members of society to access, so the over 80s, this vaccine, basically due to two factors. The vaccine is bought, as in very similar to the COVID vaccine, is actually commissioned or procured by government, and only the vaccine that's procured by government is available, so you can't buy it privately to give, and it also has to be delivered through a national programme which has got very, very strict clinical governance arrangements around it. So it's a call up, much like the COVID vaccination, and patients can book on, or they're called up by their GP to access vaccination, and then they can book up their appointment. So we also wanted to actually put it into a context of all of the other support that we do give, because ultimately the important thing is to protect as many of our vulnerable older adults, but also those of not necessarily older, but with long-term conditions, so who have perhaps a more whose immune system might not be able to cope with the vaccine. So for the majority of people, all now that we are fully vaccinated pretty much from COVID vaccine, seasonal flu, COVID-19, norovirus, and RSV, they are, well, particularly not so much norovirus, but the others, all respiratory viruses that are, for the main, not pleasant, but for most people, not going to lead to hospitalisation or death. But for a small number of those that are more vulnerable, it does lead to, obviously, can lead to hospitalisation. So we need to put it into a context that is important to encourage as much uptake as we can for all of the vaccines that are in the cohorts that are eligible to receive it. So we're really working hard through Health and Care Portsmouth to ensure that we are encouraging uptake, particularly of our seasonal flu and COVID vaccine in those groups. And there's a lot of evidence now that we have actually pretty good uptake for seasonal flu and COVID in our older vulnerable adults, but actually the group that we really perhaps need to encourage to actually receive COVID vaccine, but also seasonal flu, are those with underlying health conditions. So we know, for instance, the evidence shows that particularly, and this is nationally as well as in Portsmouth, we've had significant impact from the high uptake that we have in our over 65 population. So we have had a reduction, now that we are, I suppose, back to post pandemic, where obviously during the pandemic there was a lot of protection, not only from vaccine, but also because people were self-isolating or protect themselves wearing masks. But now we're kind of back to normal living. We've seen a 30% reduction in numbers of those aged over 65 being hospitalised. And although we are seeing significant deaths still from seasonal flu, well, mainly from seasonal, it's about 18,000 across the whole country, the uptake, particularly an older group, has had significant impact to improve that. So we always see significant number of deaths from flu, particularly from seasonal flu, every year. So we're working hard to get uptake, working with our NHS colleagues, working with our Health and Care Portsmouth comms team to ensure that we do that. There's a national campaign underway currently called Get Winter Strong. It's a national campaign which started on the 7th of October, and it's running up until and just after Christmas, so for 10 weeks. The campaign really urges those eligible to get their flu and COVID vaccination when they're invited, and we are currently in this Hampshire and Isle of Wight, one of the best performing ICB areas, because as you know, this is an NHS responsibility in terms of uptake for those that are eligible. So that's really targeting those at greatest risk, and that includes obviously very young children, but it also includes our over 65s, but those of underlying health conditions. So this is some of the ways that we are supporting our population to ensure, because vaccination is the most effective way of protecting yourself. But also there's the wider work that we do in the council. So the Independence and Wellbeing Service in adult social care offer, and I don't want to speak for Andy, but they offer really great practical support and advice to older people to reduce their vulnerability to winter viruses. So that support looks like, well, includes healthy eating sessions, physical activity sessions. You'll know that we've just had the, I think it was, is it 20-year anniversary of the supported walks programme. There's work going around growing your own, working and greening, which connects into the greening agenda as well. But as well as the work that we do, obviously, with the NHS to encourage our older, more vulnerable adults to be vaccinated. It also links in both through the Independence Wellbeing Service, but also our cost of living work. So you'll know the council has the cost of living hub, the poverty work, which also supports people around understanding where they can get access to food pantries, but also access to support around their energy bills, and also how to keep warm during winter. Now that work connects into the Wellbeing Service in public health, the Independence and Wellbeing Service in adult social care, but we also do a lot of community outreach work we've done some work around Paulsgrove, Portsdown, so there's work around ensuring we've got cost of living support officer who supports people one-to-one. There's been some really good evidence from that service recently about how many people the officer has supported to actually access all of the services that the council offer to support vulnerability through winter. So that's kind of just a kind of high level on some of the work that's happening. We'll wait to see what the evidence that comes back through the joint committee of vaccination and immunisation from the initial rollout for 75 to 80-year-olds, and depending on the evidence that comes in, how effective is the vaccine, how many hospitalisations has it reduced, I think then that will go back to the committee to see what the further decision could be, and I'll leave it there.
Thank you, Helen. Comments or questions, colleagues? Graham.
It's not specifically about RSV, it's more of a related issue. A few weeks ago I was having my COVID jab and ended up having a conversation about the supply and appointment system that operates, and I was picking up some concerns about two things. One was the supply of COVID vaccines to pharmacies, and sometimes the short dates on supplies that have been given to pharmacists, which means they don't have a long time to use them, and the potential there, and in some cases very definite wastage. I did ask if I could get something in writing, so it was a bit, because it's quite a complicated story. I haven't had that. Now that could be because the person is too busy, or because they realise it's maybe only an issue affecting them. I did raise this at the Health Review and Scrutiny Committee and asked the question as to whether we could ask pharmacists in the city, have we got anyone we can go to who represents pharmacists, who could maybe say, are there any issues with pharmacies in Portsmouth, obviously because it's Portsmouth we're talking about here, about issues of supply, about issues of the expiry dates, is this causing a problem for the use of and possible wastage? Is there any way we can find out about that and see if there is an issue there relatively swiftly or simply? I don't mean swiftly, I mean simply.
Councillor Heaney, I can take it back to our ITB colleagues. We've got the pharmacy, well, it's the pod team, which is pharmacy, ophthalmology, and thank you, dentistry. I don't think it's a local problem. I think this is a national issue. All vaccinations, much like quite a lot of the medications that are used, are procured nationally. All vaccinations are procured by government through Department of Health and Social Care. There is a very, very tight ordering process that is, because the NHS is national, it's not just local, it is national. There is a national system of pulling down, of procuring vaccines and then pulling them down to be dispensed locally across the country. There has been some issues actually locally, not through community pharmacies, around vaccines, because they do have a shelf life and obviously they're very expensive. So what they're trying to do in terms of that system, which is a national system, what would you call it, logistics system to get the vaccines where they need to be, because they have to come down to local practices. The GP practices are the main provider of vaccines for COVID-19, but of course now there are contracts also with community pharmacies. But there has been an issue nationally around ensuring that that stock rotation happens and that out-of-date stock is returned, because you can't have vaccines sitting around, it has to be returned and destroyed, but then getting the next batch of vaccine down. There's always, as you can imagine, because there's quite a tight time frame for seasonal flu vaccine and COVID-19, and it will be the same when we come to spring as well, to get it round. So it is it's quite a logistical challenge, but it does in the main work well. But I will go back and specifically ask. It does rely on whoever is the, so if it'll be the pharmacist in the community pharmacy or the lead GP in the GP practice to manage that stock rotation and ensure that it gets set back in time and that they order, because it's based on them ordering from that logistics system. So I will go back. I don't think it is a specific Portsmouth problem. I think it's a national issue, but it is quite impressive, really, if you think about the amount of stock that has to be moved around the whole country, and also the amount of vaccines in such a short time. You'll know if you speak to any GPs, they do mass vaccination clinics, often at the weekend, hence why you often get asked to have both vaccinations at the same time.
I understand the logistics, and it is obviously difficult. But a couple of things that came out of the conversation, one was the difficulty of being able to move supplies around to other people who might want to use them. You know, there's quite a bureaucracy involved, and I can understand why there needs to be some bureaucracy, but I think there's a suggestion that it's rather overzealous would be the. And the second question, and the second issue is, I was told how much a box of actually cost, and if that's being replicated across the country in terms of getting, basically dumping it, that's a hell of a lot of money to lose in the NHS when we're struggling to find money.
Can't really answer the second question, but I do agree. But that's why it's got to run effectively. But also, it's not just the bureaucracy of the logistics chain. It's called a cold chain. So the seasonal flu vaccine and the COVID-19 vaccines have to be stored to be effective, and therefore that's why you can't just take them out and give them out, even when they are, for instance, as you know, with COVID-19, we did go out. Obviously, this isn't NHS, but we worked alongside our NHS colleagues when they went out to community centres to vaccinate, etc. It has to be kept at that temperature, otherwise they are not as effective. So it's really important. It is complex, but I completely agree with you. But it is important to put it into context that it's the NHS who are leading this work, but happy to take that back and have a conversation.
Thank you, Helen. Any other comments, questions? Thanks so much for the report. I think it's it was an interesting motion when it came, and I think I said at the time it was informative for me about the situation that had been brought up. And as Helen has said, we don't have control over what vaccines are available, but what we can do is do the very best we can to make sure that our residents are having an uptake for vaccines they can have, and therefore doing that. And so, I as someone who's part of the 4 in 10 who has had my vaccine as a younger person with underlying health condition, that is interesting and a little bit concerning. But I know that when we have offered vaccines to our staff I remember when we brought it in many years ago, one of the things that we did was to make sure that the staff members who were eligible anyway should pursue that route rather than going through the ones that we fund because they get them free as opposed to us having to pay for them as a local authority. And I know that was conversations we had at the time as well with our colleagues, and I know from having worked as effectively a contract in the NHS that they do the same. So they say to people, if people work for the NHS but are eligible because they've got an underlying health condition, then they should go down that pathway and take up that one from their surgery, rather than going through the one that's been paid by the NHS. So I think that's one of the things for us to take back, and maybe we could do that at Health and Wellbeing Board, just maybe as a reminder. I mean, it's a bit late this year now, but perhaps for next year, it's just saying to all employers, even if you provide vaccines, remind your because of course some of those people, 4 or 10, might well be getting the vaccine, but they get it through their employer, but then the employer's having to pay for it, even though they would get it free. So that's a way that could actually save them money as well. And make sure that people are getting it. And it's also a good practice as well for people to say, you're eligible, get the vaccine. Okay, so again, that's for noting, and as Helen said, that was it was responsible for us to make sure that was fed back within a certain period of time from the motion that was done earlier in the year. So we can make sure that is probably mentioned next Tuesday at full council. On to item 6, Autism Strategic Action Plan 2024 to 2027. Andy, over to you.
Thank you, Chair. So the paper in front of you is related to the adult social care strategy, which prioritises outcomes for our residents around personalised support, working with partners and optimising independence and wellbeing, achieved through developing engagement with residents, our strength-based practice and delivery of our statutory functions. And the report highlights one of the ways that we aim to achieve these things. I'd like to thank Kaylee Sayers for writing the report and the work that she and her team are doing in the city with our residents. The report's a result of the Autism Strategic Action Plan that's due for publication and to evidence the support in Portsmouth for our autistic and neurodivergent residents. Section 3 sets out the national and local context for the plan, how it's been formed, and some statistics about our likely local population. Obviously, we can't be precise about our local population that may make use of these services or be for whom the action plan might be relevant. So it's a projection at this moment in time. Section 4 gives more detail to the co-productive nature of the plan's development and the estimated timeline for publication. And Section 5 sets out a summary of the priorities within the plan. And Section 5.2 gives more detail on some of the actions that will address those priorities. So we're hoping to see a flow between broad principle intention and the things that we will actually do or are doing to improve things for our residents. Section 5.3 details the initial work to ensure the priorities are owned across partners in Portsmouth. It's not just the City Council that has responsibilities here. And 5.4 sets out the governance arrangements for the plan to establish a board probably in the next calendar year. The research that informed the plan itself, the video that was used in co-production, and some more recent feedback from residents on the plan is contained within the appendices to the report. That's hopefully highlights of the report, and happy to take any questions or queries.
Thank you. Thank you, Andy. Any comments or questions, colleagues? Yeah, go on, Graham.
Just a couple. The first section talks about awareness and understanding, and I know that's something that's maybe proved problematic in the past. And you've got 3 elements there. One is called the Oliver McGowan training. I don't know what Oliver McGowan training is. Is it fairly comprehensive? Because there are 2 other elements there which seem that they may be add-ons. So can you tell me what that is?
The Oliver McGowan training was brought about by someone suffering harm, and so it's a national initiative for anybody that works with somebody who may be diagnosed as autistic or see themselves as neurodivergent. There's a couple of levels to that. There's a level for immediate awareness, and then there's a level for people doing some more intensive work. So it's one of those things that's attempted to take some learning out of adverse circumstances and then apply that nationally.
And the 2 other elements that are about the training form and the video and then the new autism training, is that going to be for staff who want to do this, or is this going to be compulsory.
What we'd aim to do is for anyone that's going to be working with our residents who are autistic or neurodivergent to have that level of training. The video is very useful. It is for wider awareness. So we are using it with businesses that are interested in trying to promote that awareness and understanding, not just across those folk that work with our residents, but also those people that are employing our residents that will come into contact. So it's more of a community aspiration, I'd suggest.
Just out of interest, I would like to see that. Is there any chance that maybe members could access it if they want to?
Be delighted to.
Right, okay. Second question relates to the annual health checks. That's got quite a long time scale on it, and presumably partly because it's identifying the people we're trying to help. I mean, do we actually have any useful data about whether we could start implementing this before year 3? I mean, the point is, can we start now and then get to a point where we're doing more people in year 3? Because it seems, from what it's saying there, that it's going to be something that's going to start quite late on, because it doesn't seem to have who will be responsible yet.
It's not something that we have seen good progress in. We do have a system of health checks for our residents with a learning disability who may also be diagnosed as autistic, and we work with our local primary care colleagues to increase those. It's about inequality of access to health, really. It's something that's written front and centre in our health and wellbeing plan about trying to address health inequalities or access to health inequalities, and it's certainly one of the primary priorities for our ICB colleagues as well. I'd probably need to get a little more information on that to be sure that I'm giving a reasonably detailed answer to it. I think it's something we're going to be trying to build rather than something that's there at the moment, and so I think that's why we've given a longer time scale to try and be realistic in being able to achieve that.
Any other comments or questions? Just a couple from me, Andy. I'm going to come back to some of the points there, but it mentions co-production. What was the nature of the co-production and how did that work?
So this was very much, we've sort of put it in chronological order, if you like. So we had that research that we presented in 2022, and that was very much done with our residents who came forward, who were either autistic themselves or neurodivergent themselves, or were carers and loved ones of people who had that life experience. And so that led on to when we were saying, well, what are we going to do about this? How are we as a city going to work on the priorities that we'd identified and some of the challenges that we'd identified in the research? That started very much from scratch. So this action plan, there's something called the ladder of co-production, which starts off at a level of engagement where let's say you've got an item and you take it to people and say, we want to do this, how do we do it? Co-production starts earlier than that with, well, we need to do something, what should we do? And then you work together to form that. So that was the level we were setting that co-production at with people, with our residents. The videos and videoing, filming how we were creating that report, that action plan, was part of that. So that was informed by people, lighting, speech, framing, how you do that kind of thing. So I think as far as anything can be, we felt that this was very much a fully co-produced piece of work.
Thank you. And then the other thing just was, in terms of this is obviously a strategic action plan from 2024 to 2027. Is there any particular financial ask in this, or is it just something that will be looked at in the more sort of general round of that? And obviously, Emma, feel free to come in on this one as well.
There's no initial financial ask. What we've managed to do is to attract some short-term funding for the resources that we have. So the team manager and the team is funded through various grants that we've managed to access. I think it will probably build over time. So there's various other aspects of our work that haven't been embedded for a long time in the traditions, if you like, of adult social care work. But as they build, we make business cases, we consider where we get resources from and how we also use our existing resources. So part of our workforce strategy that we're working on currently in adult social care is to think about, well, what skills do we have in the workforce, what skills do we need to build in the workforce, and how do we create that. If I was to give a detailed example of that, because I always find it helpful to talk about examples rather than sort of generalities. Let's say we had someone leave in a particular post from adult social care. Do we replace like for like, or do we think about what we need in the future and make a change in how we're using those skills and what posts we put in, that sort of thing.
Did you want to come in at all, Emma?
No, thanks.
That's fine. And actually, just thinking about one other thing was, in terms of numbers of people with autism, are we seeing an increase of diagnoses?
There is, and I can't remember if we've identified that in this report, but it was certainly identified in the research, if not now when, then there is still a very significant waiting list for a diagnosis. And I think on a human level, you absolutely understand why people want a diagnosis. It's either seen as, well, this sort of justifies that we knew there was something that needed to happen, or we knew there was something that needed support, or it can be seen as a gateway to services and support. The way that we've tried to frame this is very similar to the approach that our colleagues in children's social care have taken, in that if you have needs that are relevant, equivalent, broadly equivalent to somebody with a diagnosis, why wouldn't we meet those needs? Why wait for that diagnosis? So there's still a very long waiting list, both nationally and locally, for a diagnosis of autism. So we're interested far more in working with the needs that are created, which is also the statutory basis in the Care Act.
Thanks, and I think that's a really good point to make, that we don't rely on diagnosis to support people. We very much go on needs, which is the better way to do it. This is a really important action plan. I think I would just pull out a couple of three areas. So one is co-production, and I'd also draw colleagues' attention to the feedback from autistic people that we've got on the Appendix 3, which is a really interesting, really positive, actually, about the feedback that they've had on the process of that co-production, but also some of their comments about ways that we need to be thinking about as well. So it is from their, they're experiencing these services, and they're experiencing life as someone with autism, and therefore they know, they are experts by experience, as we always call them. And then the other bits that I was just wanting to pick out were about of the aims of this in terms of the action plan itself are the ones around because we think about health and well-being and all that kind of thing, is about the housing and the employment side, because getting the right housing for people with autism is really important, especially independent living, to ensure that there is independent living options, and especially when people go from transition from being a child to an adult, so that they're not in a situation whereby they're having to live in a home, and whereas there's other people, maybe many of their friends are sort of leaving who don't have autism, are leaving and going to live independently. If we don't get that housing side right, then that can really stymie their ability to live independently. And then the employment side, because that can be a real gateway into so many other things, and indeed has such an impact on well-being as well, if people who have the right support to get people into work. I was fortunate enough to go to to open the new Room 1 facility in Somerstown a few months ago, and it was absolutely fantastic to see that facility, which is peer-led, and that's another really important thing that we do in Portsmouth, and we are well known for doing in terms of supporting our peers, people with lived experience, to lead on the support they give to other people with autism. So that is something that I think we should be, again, really proud of, and that is in conjunction with our people with lived experience and our partners across the city as well. And again, it was one of those things when you go to those kind of environments, it's about talking to those people with lived experience, those peers, about the experiences they've had, and about why they want things to be better as well. And that's often what you get with people with lived experiences. Their experience might not have been as good, especially those who have had diagnoses and been with autism for many, many years. But what they always want is for it to be better for people in the future, and they want to do their bit as well. So I'm really pleased to see this plan. It's a plan that we will obviously be held to account on as an administration, as a council, but obviously we will make sure that we are keeping to it and doing the very best for people with autism in Portsmouth. So moving on to the final item, item 7, developing strength-based practices in adult social care. Back to you, Andy.
Thank you, Chair. The SE strategy prioritises support that helps residents optimise their health and well-being, and developing strength-based support as a way of working in adult social care in Portsmouth. So this report evidences the work to embed strength-based practice in adult social care in Portsmouth. I'd like to thank Vernon Nosal and Marika Cochrane for writing the report and the work they're doing to support adult social care with our strength-based practice project. Section 3 of the report sets out the vision of the adult social care strategy and how this aligns with the council values and the statutory basis for work under the Care Act of 2014. Section 3 also sets out the processes, activities and method to develop strength-based practice in Portsmouth, and that section also gives us some detail around the work stream developed and the intention to develop an implementation plan, which is our next step. Finally, Section 3 highlights the significant change within adult social care and the importance of ensuring that practice is embedded, which will be supported by development of performance indicators to measure progress in terms of resident outcomes, workforce satisfaction and value for money. And those three things form the bedrock of knowing that we've managed to embed that practice. We will bring back further updates and evidence of the impact for our residents to future decision meetings, but that's a summary of the report.
Thanks, Andy. Any comments or questions? No. This is an important thing, strength-based practice. It's something that has been rumbling away for a while now, and this is really sort of just moving that on to the next stage. As Andy says, keeping up to date on how we're doing it, and it is very much about making the very best use of our staff, their skills and experience, but also again talks about collaboration. It's with our partners and with our residents as well. So and it's something that when we're looking at making the best bang for our buck, it is really something we need to embed across there. So that is noted, and that concludes today's meeting. Thank you very much. It's been a long one, but I think there were some really valuable reports in there and some really interesting and good work going on. Thank you very much, everyone.